I'm Catherine Buchan. I'm a sleep and respiratory clinical nurse consultant at Alfred Health and work with patients with acute on chronic and chronic ventilatory failure with using non-invasive ventilation and high flow and standard oxygen therapy. So today I would like to talk to you about the use of high flow nasal prongs in the emergency department and transferring to wards and what the evidence there is in the emergency department. There's been recent studies that have been looking at non-differentiated dyspnea and hypoxemia in patients who present to emergency department with low oxygen saturations and high work of breathing, and what to do with these patients. Traditionally, standard oxygen therapy has been used routinely in emergency departments, and whilst that can improve the oxygenation saturations, it doesn't always have a big impact on the work of breathing depending on what the underlying cause is. So one of the tools that can be used is high flow nasal prong therapy, and these devices are airflow generated devices that actually have the ability to warm and humidify the air gas, and you can titrate oxygen saturations to oxygen that's actually included into the device. So the evidence is showing that in undifferentiated dyspnea and hypoxemia that there is a slight reduction in respiratory rate and improvement in dyspnea scores and comfort for patients using high flow nasal prongs. The comfort isn't universal, and some patients do find it difficult to tolerate. There's been some emerging other physiology studies showing that there is a reduction in work of breathing and respiratory rate, and some washout of upper airway, nasopharyngeal, carbon dioxide too. So there's some interesting work still to be done on the mechanisms of actions in patients that have got compensated hypercapnic respiratory failure and so forth. But traditionally the device is used in type 1 hypoxemic respiratory failure, and non-invasive ventilation should be used exclusively in patients that have got hypercapnic respiratory failure.